Welcome back to The Explainer, everyone. Okay, grab your mental notebooks and let's get right into it. Because today, we are setting the stage for a high-yield, high-energy crash course on rabies and rhabdoviruses. Whether you're grinding through board prep or you're getting ready to see patients in the ER, you absolutely need a rock-solid understanding of what is, frankly, one of the most fascinating and terrifying infectious diseases on the planet. Let's break down exactly what you need to master.
I really want you to think about this terrifying dichotomy we pulled from the source material. It's virtually 100% effective when given correctly, but almost universally fatal when symptoms appear. Let that sink in. There are only about 33 documented survivors of rabies worldwide, in all of human history. Once those clinical symptoms manifest, there's no established antiviral treatment. It's over. But if you intervene early and correctly with post-exposure prophylaxis, it is completely preventable. So as future clinicians, knowing this protocol isn't just about passing a multiple-choice test. It is literally about saving lives.
Okay, let's dive into this. Here's our syllabus for today's masterclass. 1. Virology and pathogenesis. 2. Epidemiology traps. 3. Clinical presentations. 4. Nailing the diagnosis. And 5. The PEP protocol. Starting off with Section 1, Virology and Pathogenesis, the bug and the path. So what kind of virus are we actually dealing with here? The rabies virus belongs to the family Rhabdoviridae and the genus Lyssavirus, which is pretty fitting since Lyssa is the Greek word for rage or madness. Under an electron microscope, it's got this highly characteristic bullet shape. Genetically, we're looking at a single-stranded, negative-sense, non-segmented RNA virus. But listen up, because the absolute most crucial point for your exams and for making the vaccine is the glycoprotein, or the G protein. This surface protein is the star of the show. It mediates viral attachment and entry into the host cells. Because of that, it's our most important protective antigen, making it the exact target for our neutralizing antibodies and the whole basis for our vaccines.
So how does this little bullet-shaped virus actually take down a human? Let's walk through the pathogenesis timeline. First, a bite deposits the virus into muscle tissue. It just hangs out there for a bit and binds to nicotinic acetylcholine receptors at the neuromuscular junction. Second, it starts its centripetal journey, meaning it's heading straight for the central nervous system. It literally hijacks retrograde axonal transport, inching along the peripheral nerves at about 250 millimeters a day. Third, once it hits the spinal cord and brainstem, it rapidly disseminates throughout the whole CNS. And then, step 4, it switches gears. It starts centrifugal spread, moving away from the CNS, traveling down sensory and autonomic nerves to the skin, the heart, and critically, the salivary glands, where it's shed in saliva to infect the next host. Now, during this massive CNS takeover, the virus leaves behind a very classic histological footprint. We're talking about Negri bodies. These are eosinophilic cytoplasmic inclusions found inside neurons, specifically the Purkinje cells of the cerebellum and the pyramidal neurons of the hippocampus. If a pathologist sees Negri bodies on a brain biopsy, boom, it's a diagnostic home run. They are pathognomonic for rabies. However, write this down in big, bold letters right now. They are not always present. So if you don't see Negri bodies, that absolutely does not rule out the disease. Moving right along to Section 2. Epidemiology traps. Let's look at global versus U.S. reservoirs. I'm going to give you a strict warning right now about a classic board exam trap. If the question asks about global rabies, the answer is dogs, period. 99% of human rabies deaths worldwide come from dogs. The global burden is around 59,000 human deaths every single year, predominantly hitting children and rural populations in Asia and Africa, where canine rabies is still a massive, tragic public health crisis. But here is the massive contrast for the U.S. In the United States, endemic canine rabies has been eliminated. The most common cause of indigenously acquired human rabies here? Bats. We're talking silver-haired, tricolored, and Mexican free-tail bats. And the truly sinister part about bat transmission is that their teeth are incredibly tiny. A bite wound can easily go completely unrecognized. A patient could literally wake up with a bat in their room, shoo it out, and never even realize they were bitten. Let's move to Section 3, Clinical Presentations. Furious versus dumb rabies. Okay, so after an exposure, the incubation period usually lasts anywhere from 20 to 90 days, though it can vary depending on how close the bite was to the face. The very first clinical clue, the key early prodrome sign, is pain, paresthesia or severe itching right at the healed bite site. The original wound is long gone, but the dorsal root ganglia are infected, causing that localized nerve pain.
Once the acute neurologic phase kicks in, the disease splits into two distinct presentations. On one side, we have encephalitic or furious rabies. This is 80% of cases. These patients get prominent brainstem dysfunction. They develop hydrophobia, which is an involuntary, excruciatingly painful contraction of the respiratory muscles when they try to swallow liquids. They get aerophobia, hypersalivation, causing that classic foaming at the mouth, and terrifying hyperexcitability that strangely alternates with perfectly lucid intervals. On the other side, making up the remaining 20%, we have paralytic or dumb rabies. These patients don't get hydrophobia. Instead, they present with flaccid weakness that starts in the bitten limb and slowly progresses to full quadriparesis. And that right there brings us to another massive clinical pitfall. Paralytic rabies is frequently misdiagnosed as Guillain-Barré syndrome, or GPS. Because it presents with ascending flaccid paralysis, it looks incredibly similar to GBS on the surface. So how do you tell them apart? Listen closely. If the patient has a fever, bladder dysfunction, a normal sensory exam, and CSF pleocytosis, you need to be favoring rabies over GPS. So how do we prove it? Section 4. Nailing the diagnosis with high-yield testing. Let's run through the specific diagnostic tests you need to order ante-mortem, meaning while the patient is still alive. Drill in on this first one. The highest yield ante-mortem test is a skin biopsy, taken specifically from the hairy skin at the nape of the neck. Why the neck? Because the test detects the rabies antigen in the cutaneous nerves that live right at the base of the hair follicles. You can also use RT-PCR on fresh saliva, which is highly sensitive and can even tell you the specific animal variant of the virus you're dealing with. Finally, checking for neutralizing antibodies in the cerebrospinal fluid is highly specific and strongly suggests rabies encephalitis regardless of whether the patient was vaccinated before. And finally, Section 5, the PEP protocol, the life-saving protocol. If you've spaced out, come back to me right now, because if you remember absolutely nothing else today, remember this protocol. It is virtually 100% effective if done right. Let's break it down. Step 1 is non-negotiable. Immediate wound care. Wash that wound out thoroughly with soap and water immediately. Do not skip this. Step 2 is deciding if PEP is even needed. Domestic dog or cat, observe them for 10 days. If they stay healthy, no PEP. But wild animals like bats, raccoons, or skunks, euthanize and test immediately or just assume it's rabies and start the PEP. Step 3, we administer rabies immune globulin, or RIG, to give immediate passive immunity. And step 4, we give the rabies vaccine to stimulate the patient's own active immunity. But hold on, because the protocol changes entirely depending on the patient's history. Let's draw a hard line here. For a previously unvaccinated patient, they get the whole shebang: wound care, RIG, and a 4-dose vaccine series. But if a patient has been previously vaccinated against rabies, like a veterinarian or a wildlife biologist, they get wound care, only 2 vaccine doses, and absolutely no RIG. Giving rabies immune globulin to a previously vaccinated patient is a major, major clinical error. Let's talk about the precise rules for administering these, starting with the RIG rule. You've got to infiltrate the rabies immune globulin directly into and around the actual bite wound itself, if it's anatomically feasible. And this is crucial. You can give it no later than day 7 after the first vaccine dose. Why? Well, because after day 7, the patient's own endogenous antibodies are kicking in from the vaccine. So adding passive immunization at that point actually becomes counterproductive. Next up is the vaccine rule. For our standard unvaccinated patient, we're doing 4 doses on days 0, 3, 7, and 14. And here is my forceful warning to you. Inject this vaccine only in the deltoid muscle. Seriously, if you inject it in the gluteal muscle, the fat tissue there can literally prevent the vaccine from reaching the actual muscle layer, and that leads to fatal vaccine failures. Deltoid only, guys. All right, rapid fire summary time to cement the highest yield exam traps before we wrap up. USA main reservoir, bats. Pathogenesis, retrograde axonal transport to the CNS. Paralytic rabies, it's a sneaky Guillain-Barré mimic. Gold standard antemortem diagnosis, skin biopsy from the nape of the neck. Vaccine location, deltoid muscle only, never ever the glute. And rabies immune globulin, strictly contraindicated in previously vaccinated folks. To end today, I want to leave you with this provocative clinical scenario. A patient comes into the ER with flaccid weakness, a fever, and bladder dysfunction. They mention they woke up with a bat in their cabin a month ago, but there are absolutely no visible bite marks. Is it Guillain-Barré syndrome or paralytic rabies? Based on the fever, the bladder issues, and that high-risk bat exposure, you know exactly what to suspect now, and you know exactly how high the stakes are. Keep reviewing this material, stay curious, and stay focused. You are well on your way to crushing these high-yield concepts. See you next time.